quickly, if you say slow down, and if you have any questions as we go along, we'll try to entertain those, although we are on a certain time schedule. So I want to welcome you to this learning collaborative that you're part of, and I think you should give yourselves a hand for the work that you've done so far. And I'm going to start off initially with the logo significance. You know, in every venture, you need to take a look at what the symbol is for what you're trying to accomplish. And you can see the initiative for the Mississippi Qualified Improvement Initiative 2. And the key thing for me in this is that there's a couple. One, it says 2, so that means it's not just one person in your organization, one person trying to do all the work. 2 plus 3 plus 4 plus 10. It's everybody. And take a look at that Q. You see how that Q is shaped, and it's got a long tail to it, which means that this will never end, which is fantastic. And that a lot of things we stop and start. I may start cleaning one room of my house, never finish, and 10 years later I go back, the same junk is there. But in this initiative, we're going to start at a certain foundation, and we're going to move forward. And let's see if I got this right. Okay. Oh, wait a minute, hold on. Is it going to come on? There's supposed to be a portion that comes with that. It didn't come across. But basically that was the component about our lessons learned, or what we're here to accomplish in our objective. But I'll go on. I want to give you some background information about this process. Some of you are familiar with this and some of you may not be. But I really just want to put it here so that you can reference this as you move forward. From the standpoint of how we got to this point, there was a report done, and there was a report done by the Institute of Medicine. It was done a number of years ago, but it was the foundation for all the work that we're doing now. And the key things, there were a number of components, but there were 6 key components with reference to this report. One dealt with healthcare, and that it should be safe so we can avoid injuries. And you know we have a lot of problems with that in handoffs and everything else. Also, healthcare delivery should be timely. And ideally, it would be nice if you can pre-work everything electronically before you go into your provider. You go in, you check in the receptionist, and 20 minutes later you're out the door with all your medications and everything else. And how many of you all have that in your center right now? From the time you enter the door to the time you leave, it's 20 minutes and everything is done. That's what we'd like to see. Right now it may be 30 minutes, maybe 4 hours, and maybe 5 hours. The other thing is that we want it to be efficient. We don't want people doing the same thing, redundant work. So the objective is to make sure that we're doing things in an efficient manner. So in doing this, we also want to make sure that it's effective in that the services we render are based upon evidence-based guidelines, and that this is the standard of care that we want to follow. And a number of scenarios are in place around that, in that with reference to hypertension as an example. There's been the change to the JNC9, and with the change in hypertension, a number of people still have not adopted the measures with reference to evaluating hypertension based upon the age of the patient. But that is something that we have to do, so that you don't want to take an elderly patient and try to keep their blood pressure at 120 over 70. The other thing is that we want our care to be equal, in that we don't want to vary from person to person. The same care that you give to your mom, you want to give to someone who is from, quote unquote, the wrong side of the tracks. Quality has to be, care has to be equal, and it has to be just, and we want it to be fair so that everybody receives the same level of care. And the other thing is that we want it patient-centered, and what that means is that the patient is in charge of their health care. Each individual is in charge of every decision you make every day of your life. For some reason, when it comes to health care, we have a tendency to rely on our health care provider team. And the healthcare provider team wants you to rely on them in that they want to tell you what to do. They want to give you a prescription. And when you go back in, they will say, you did take that medicine, didn't you? And you are going to say, yes, I did. But the patient has to be empowered. We all make decisions every day, whether they're right, wrong, good, or bad. And from the standpoint of healthcare, the only way we're going to make a difference is to ensure that our patients are empowered and that they are in control of their health. And we accept them being in control. In that we are not God, we don't want to have the God complex, and some of us say that we do, but that is not what we want. We want patients empowered. So this is the original design that was done through IHI, and this is the process we went through years ago, and was called the Breakthrough Series, just to give you an example of what happened. And in essence, we're doing the same thing with this program. It's just in sort of a condensed format in terms of the learning sessions and the components related to it. Now, this is the model that was designed by Dr. Ed Wagner of the McCall Institute, and this is the model that your pre-work manual was based upon. And these are the components, and we will be spending quite a bit of time on this today and with the other 2 learning sessions. But this is the key model and some of the components that were done. And it is an excellent model to use, and it's been used in all forms and fashions and throughout the world. If you go to the various websites, you'll see that Russia uses this model, France uses this model, British Columbia uses this model in various forms. Okay, there was a quote by Robert Frost: home is a place where when you have to go there, they have to take you in. That is what we want to become, and that's what some of you already are, but you want to expand that so that when a patient comes to you, you're ready to take care of them. And to be ready, this is what this process is all about, to help you become ready. Okay, change. Change is something a lot of people don't like to hear, but change is going to be there. Your body changes as you get older, your kids change, your mom changes, change is just inevitable. A lot of people are resistant to change, but it's there. And there are certain key things that we have to be able to do if we're going to address health disparities. And what we're using today is known as planned care model, and there are a number of the change care components that we're going to address. Change is usually something that we talk about at a really high level, but we have to simplify it so that we realistically know how to do that. And that means that we establish these teams, everybody has a certain role, but you're working together, and that you are handing off information so that it's not repetitive. We don't want you to repeat things, we want things to be really more efficient. And you have to consider all parties in the system. Everybody deserves a level of respect. We don't always give that to them. We may bring our personal problems to work, but hopefully through this initiative and what you're going to learn, hopefully we'll learn how to leave those at the door, but if we don't leave them at the door, we'll learn how to handle and deal with them. The key components that were in the model that we will be talking about throughout the day and all the learning sessions deal with decision support, and decision support deals with the component around evidence-based guidelines so that we know that we are utilizing key measures, and you receive those key measures as we address these disease states. Delivery system design deals with how you're going to present the services for the patient. It may be for an individual patient, it may be for a group, but in delivery system design, you're going to think about everything you do every day, and whether it's for the individual patient or the group, you will go through a process to ensure that you capture all the components and you're efficient at doing it. From the standpoint of clinical information systems, in this day we have electronic health records, and I have a number of positive comments about them, a number of negative comments when it comes to electronic health records. In my ideal world, we would have had a higher entity, and I'll say CMS is that entity, to ensure that although we may have different electronic health record systems, we already had the health information exchange component built in. Because in this day and age right now, where we are is we may have an electronic health record system, but we may have patients who see 4 or 5 different providers. And we have to have various portals set up, we have to have secured faxes and emails, and then I heard one patient say, well, I actually have 6 username and passwords to 6 different portals. So that is not what we want, but that's the world that we're living in. And also with your vendors for the electronic health records, they sell you a great package, you think, until it comes time to exchange information. Then you get hit with, it's going to cost you this amount of money, and it's going to cost you this amount of money per user and per provider, but don't get me started on that. Self-management. Under self-management, that goes back to being patient-centered and empowering the patient. Self-management does not mean we give you the guidelines for diabetes, and we say that we want your hemoglobin A1C to be less than 7, and then from that perspective, we tell you what to pick. We tell you need to exercise 5 times a day for at least 40 minutes. We tell you that you need to only eat chicken or turkey. You know, we don't do that. Under self-management, we find out where the patient is and we move forward. Because when we try to start telling them something, then we may run into trouble. And I've told this over and over again, in that we had a project going one time where we did this component dealing with meat and trying to see how we were doing with our patients and measuring what they were eating. We were discussing red meat, and we were also measuring values as we go along: glucoses, hemoglobin A1Cs, weights, BMIs, the whole 9 yards. And what we found out in doing one of the PDSAs is that we talked a lot about red meat, ground beef and pork chops and steak and all that type of stuff. And then we found for some of the patients, instead of the measures going down, they seemed to be steady or going up. So when we did one PDSA, we found out that when we said don't eat red meat, and we found out that from the perspective of several other patients is that they weren't eating red meat. If you cook hamburger meat, what color does it turn? You prepare a steak, what color does it turn? So you have got to be able to meet the patient where they are. You cannot take anything for granted. Another example dealt with, we were talking about trying to empower the patient, and we used a scenario around a car and a vehicle. And when we did that scenario, we talked about how, as a team, and with diabetes, we could provide the windshield wiper blades, and the wiper blades would reference going for your eye care. So make sure that your vision was fine if you had diabetes. We talked about foot care and putting your foot on the pedal and those type of things. The answers we got back was 1, don't drive. 2, don't have enough money for gas. So you've got to meet the patient where they are. You can't just assume that you come up with this great idea and this great concept and it's going to fly. You need to test it and see, is this realistic for this individual patient or group of patients that I'm dealing with, and realizing you're going to have to do different things at different times. So just don't assume anything, because you know what assume does to all of us. And from the standpoint of the healthcare organization, that includes you and everybody within your agency, but also it ties closely with community in that you have key partners that you must work with. And those key partners would be political partners, business partners, other healthcare entities that are within your organization, religious, faith-based community organizations, service industries, everybody. The food stamp office, a WIC, you name it, they're involved if you're going to make sure that you provide the care. Okay, and this change package is applicable to a number of disease states. We're addressing chronic diseases, but I just wanted to stress the fact that under this change package and everything that you learn, this is applicable to all the work that you do. So it's applicable to the chronic diseases, prevention, acute care services, medical and dental conditions such as perinatal programs, sealants, anything you want to do. And it should be organization-wide, and if it's organization-wide, you're going to improve patient safety, and you will have continuous performance improvement. Our social system, we got to understand that there is no way in the world that we can conduct a collaborative learning sessions of any nature if we don't know what social dynamics are going on. And in Mississippi, there are quite a few. So in any environment, you've got to see exactly what's going on with your patient, your group of patients, because you may set up this great self-management model, and that grandmother has a 19-year-old grandson who is on crack, stealing her medicines, stealing her money, and so her biggest issue is how to address that 19-year-old grandson. You may have a mom who is 40 years old and she's on child number 12, and you're asking her to take care of herself, and she has to ensure that she gets up at 4 o'clock in the morning to get at least 6 kids off to school. Then she has to take care of the other ones during the day. She has 5 baby daddies. So you got to deal with the social system that you're in. And then you also may have, on the other perspective, that patient who utilizes the internet, goes to WebMD and comes in to tell you, I have this, and this. And you got to be able to be ready for that. You got to be able to deal with Facebook, Twitter, Instagram, all of those components, because the stuff that is said on those sites, a lot of people take that and they believe that's true. So whether you want to be on Facebook or not, or Instagram or Twitter, even know how to use it, you got to. So you got to deal with your social system, because if you don't, you won't be able to impact the patients the way you would like. The evidence-based guidelines, I can't stress this enough, in that everything that you do, you want to make sure that you're doing it by the standard of care. Because the way we are going, we are judged by quality. Now, I realize we're not being paid for providing quality service, but I'll put it like this. We're not being paid to the extent we should be. There's still this disparity between, and no offense to those if you do have an instrument that you use, but if you're a provider with an instrument, so if you're a provider with, I'm going to get in trouble, but a provider with a couple, or you're a provider with tools to perform surgical procedures, or you're a provider and you can perform pulmonary function testing, you submit your claims, you get reimbursed quite a bit more. For the quality of services that we are rendering and the measures that we're doing, the dynamic is not in place yet so that we receive the funds that we should. It's moving that way, but it's not there yet. But from the standpoint of evidence-based guidelines, we must adhere to those because the payers now are asking you not only to show a process measure where you ordered the hemoglobin A1C, you did the LDL, but when you submit your claim, you must put the value for the hemoglobin A1C, the value for the glucose, the value for the LDL, when you submit your claim if you're going to get paid. So although we're not getting a big jump in pay, if we still want to get paid at all, we still have to make sure that we follow those guidelines. And there are just a couple things in that the evidence-based guidelines and the change package, just to say that we've got to use something to try to see how well we're doing. And Plan, Do, Study, Act is the model for improvement that we have in place. And this is a continuous, ongoing process. And from a Plan, Do, Study, Act perspective, the PDSAs that you conduct, don't think that anything is not worth doing, in that you learn more, in my personal experience, from those that fail than from those that are successful. So the plan for the PDSA model is very important, and it's something that you really have to delve into and constantly work at. It may be very frustrating at times. And when I work with various teams, the Plan, Do, Study, Act became, please do not start another. But the thing is that you have to, and you really have to keep it going. And then once you do that, from the lessons learned with your PDSAs, then you take that to the next level. And the other thing is that you will identify training needs as you move forward throughout this process. And there is no dumb question, there is no stupid question. Make sure you ask so you can get things answered, because you want to ensure that you are on the same page with each other as you move forward in this process. And one thing that we did a number of years ago was the concept called NEPMA. Nobody ever tells me anything. And I know you all don't hear that within your organization. But I've heard that over the years, and that things are started, things are implemented, and they say, well, nobody ever told me that. So one thing that you may want to consider is some form of communication in the form of a NEPMA, in that you are ensuring that from top to bottom, everybody within the organization is involved. It is not just the team that's here today. You're representing your agency and your organization, but this is something that you're going to do so that lessons that are learned, and as you move forward, that they know what's going on and are actively involved and actively engaged. And the other thing deals with Teach Back. And Teach Back is a key component when it deals with working with your team, working with your patients. And one thing that I've learned over the years is that as a provider, one thing that you shouldn't do is, as you finish up with the patient, put your hand on the doorknob and say, do you have any questions? That's the last thing you want to do. You want to examine your patient, talk to your patient as you go along, and then as you explain something, then you say, Mr. Smith, now what did I just say? And then see if they really understand. And even in your team sessions, and even with me today, under Teach Back, I would want, if I made a statement to you, I want you to explain it to me so I can see if you understand what I said and if we're on the same page. So that's an important component. And all this involves the patient, the family, the community, the providers, the healthcare team, your organizational leadership, support, and enabling staff. So it's everyone. And these are just some of the lessons learned, and then I won't go through all of them, but your data needs to be transparent, and that everybody needs to be able to know what's going on. There's no such thing in this day and age that you can make up good figures and good results. You're going to get in trouble. And I said that I'll go to jail for certain things, but I won't go to jail for undercoding and overcoding. So there's certain things that you've got to make sure that you do so your data is done correctly. And make sure that you develop your strategy to make sure that they stay deliberate, so you stay on task and on track. And I have a tendency to veer off course, and there's some of you in the room who know that. I can get into a discussion and can go off track, but make sure you stay on track with this. And your leadership has got to be aligned with the work that you do. Also, you got to celebrate as you go along. I have been involved in a number of teams over the years, and the teams that are really into it and really want to work, we fussed and we fought and we did all kinds of things, but it was successful. We had a good time and we celebrated that. But trust me, we did not have the same opinion on things, and that's good. You know, you don't want a team where you got one person talking, as I'm talking now, and everybody else is just looking and listening, never saying a word. You want everybody engaged, and you are going to fuss and you're going to fight, but it's for the same purpose. And then you're going to celebrate your successes and have a good time. So that's important to do that. Then you're going to identify those things at a high level that are going to make a significant change in the management of your patients. And the key thing that you do as you go along is utilize a method to keep track of what you do. One thing that I think is beneficial that you can use is to come up with a format for your team meetings so that you can utilize something such as Agenda Wizard. How many of you are familiar with Agenda Wizard on Microsoft? Because under Agenda Wizard, you set your agenda, and it has the components in there, so as you go through each thing, you can identify the item, the discussion, the responsible party, the deadline for completion, and utilize that every time, so that when you come to meet, you have a concrete document, and I say concrete, but virtually concrete, because we're trying to be paperless. But the idea is that you utilize something to make sure that you move forward, and that you provide opportunities for other staff members to be engaged. Because if you're engaged and you're actively involved, they will become interested in what you do, and that goes a long way. Okay, the clinical versus the admin issues that some of you may or may not face. There's always this scenario, and I've been in, again, a number of situations where the administrative office is actually called the White House, or it's called the Palace, and only certain people can enter, and you got to bow when you go in, and all those types of things. Those barriers have got to come down. So that is why we're here today, and you're going to have sessions with breakout, and there's going to be a session for leadership. But this is something that everybody has to buy in, and everybody has to do. So there is a chief and there are Indians, but there are ways the chief and Indians work together. It's not a thing where we're going about trying to sabotage each other. So there are some things I know from a historical perspective that may have happened in the past. Please let them stay in the past so you can move forward. Because basically you want to make a business case for why you need to do this. And you need to do this because we want quality of care. We want everybody to live to 105, 110. Because I actually get offended when I hear someone died at age 72 and they say, oh, they were really old. I don't think 72 is that old. So we need to make this case so we can get things changed. Or as I had a 9-year-old tell me once that his teacher was really old. I said, oh, babe, how old is your teacher? Oh, she's about 30. No. We want to make sure that we can do this work. The other thing is that we've got to utilize our data, but our data systems are challenging, but we've got to be able to show how we link the financial to the clinical outcomes. Because at bottom line, and that's what we have to be able to show, that the data that we produce, the quality of care that we provide, and those measures will improve the financial situation for your organization in terms of we will be paid for quality. But the other thing is that the more that we can keep patients out of the hospital, the more that we can help to lower that blood pressure, lower their hemoglobin A1Cs, the more likely they are to come to us for their visits. And then ultimately, we're slowly moving toward that point. We should receive a high level of reimbursement. Unfortunately, the world is not set up yet so that primary care receives the recognition that it should. But once we get there, you all will be ahead of the game in doing that. Lessons learned. It's a process and it takes time to get it done. At the bottom of this it says resistance to change is always out there. So don't think that you're going to have a sunny day every day. There are going to be bumps along the way, but stay encouraged because you know that you'll be able to achieve. Okay, and measuring, you gotta measure everything that you do as you go along. So that's very important that you do measure all the things that you do, and that means you have to document. Again, virtual documentation is what I'm talking about in this day and age, but measurement is key. So you've got to make sure that you're doing things where you have a numerator and a denominator in getting things done. And you got to convince others that you have problems that you need to work on. But again, the way you do that is by utilizing the data that you have in front of you, or the data that you can achieve from within your agency. And in your manual, you receive a number of codes that you can use from an ICD perspective, a CPT perspective, a CPT2 perspective, and a HCPCS perspective to help you pull that data to show what you need to accomplish. And this is just showing that what happens is that we're dealing with comorbid situations, in that in a number of articles and a number of things that have been done over the years, diabetes and cardiovascular disease are part of the same spectrum. So in essence, you are dealing with patients, and I know a number of your patients have both, or if they don't have both diagnoses now, they have enough indicators that eventually they will have it. So you're dealing with this, and you need to take it from that perspective, in that I hate when I hear someone say that someone died of a heart attack, and I said, oh, what happened? They said, well, they had to have about 4 or 5 bypasses done, and they died of a heart attack. They don't mention anything about their diabetes, and about the diabetes being poorly controlled, and the idea that it was actually the diabetes, poor control of diabetes, that led to the cardiovascular condition that led to the heart attack. There's this disconnect in our minds, in the world, between diabetes and hypertension. They both go together. They flow along the same process. And why do we have to address these comorbidities? And this is just some figures, and you'll get this PowerPoint presentation. But it just tells you that we have patients with a number of comorbid conditions, but they see multiple providers. And when they do that, we don't have that ability yet to ensure that we do what we need to do. So we're to serve as those gatekeepers. We're to serve as the ones to ensure that they receive the care that they need, because care is still disjointed, unfortunately. And with this Learning Collaborative, you're going to learn ways to ensure that you bring all that under your umbrella. And then why is this needed? And it's shown for a number of reasons that as physicians, we know that poor care coordination produces poor outcomes. We also know that